Although Dr. Silk is our moderator, I don't think he should introduce himself. So I will do it. I probably won't do him justice because his credentials are a mile long. But he is a professor at the University of Michigan. He's been there for many years. He is instrumental with the American Psychiatric Association this year, leading the organization in terms of personality disorders and what will be presented at the conference in Philadelphia. He's the secretary-treasurer of the International Society for the Study of Personality Disorders, and we're very proud to say that he is chairman of our website, our scientific forum website. He's the chairman, along with Drs. John Gunderson and Dr. Oldham. So it's my pleasure to introduce Dr. Silk, and I'll ask him to fill in anything that I haven't said. Thanks.
So Brian ended perfectly on time. I think he's gotten more precise since he's moved to Minneapolis. I meant to Minnesota. They're kind of clean and neat, very organized. He said that I'm a world expert on psychopharmacology. I guess I should qualify that by saying I've not really done first-person research on it. What I've been doing over the last couple of years is trying to compile the work that other people have done to try and make things, to try and clarify things, or to try and figure out how one works one's way through what might be contradictory evidence or findings in the studies that have looked at psychopharmacology. So I'm going to kind of talk about that, but I'm going to go through that section of the presentation quickly because it's a 50-50 divide, and it's all in the handout, so if you care to look at that. But I'm going to kind of pass over it reasonably quickly leaving out the details, but trying to show you how I try to compile what I think, at least at this point in time, in November of 2011, what it looks like with respect to how we should think about which pharmacologic agents to use in these patients. But I'm happy to take more specific questions, and when we get there, I'll say that in more detail. So in the world of medical fields, we have to do disclosures. These are my disclosures. We were having dinner last night with Randy, and she was telling us how successful her book, Don't Walk on Eggshells, would be. And when I figured out all the royalties from the books I've done, it could probably buy me one of those trays of pastries outside, but not a refill. So I get royalties from the American Psychiatric Press, Cambridge University Press, and Up to Date. I want to co-edit-in-chief of a journal, which doesn't come with compensation. And though my son works for Pfizer, I don't have any direct financial relationship except that I don't have to send him money. And I'll be talking about the off-label use of psychiatric medications. Though he did get married in September, so there was a little exchange of money at that point. So what Brian had said is important, and I want to kind of emphasize this. There are people who think that you should not use medications with borderline personality disorder. Though if you put them in a bare room with a single light bulb over their head and turned up the heat, they might admit that there could be certain situations where you might want to use medications, but they would often say, and I think that this is a strong point that they make that needs to be kept in mind, is that there's no evidence that using a medication and then using it continuously for years and years and years can necessarily be effective. It doesn't mean that it's not effective, but the longest ongoing study of medications that's been done has been 16 weeks. And Brian mentioned that at least the mentalization-based psychotherapy has now looked at 8 years. So we don't have any long-term studies. But that one needs to kind of think about that, because once people can get attached, and therapists can get attached, and family can get attached to believing that the medications are what is leading to behavioral change or better emotion regulation, but we don't necessarily have a lot of evidence to support that. But despite the fact that there are people who believe that medication should not ever or very rarely be used, and this includes the NICE guidelines, the National Institute of Clinical Excellence, from the United Kingdom's guidelines that really are pretty negative about medication, certainly about ongoing use, that medications are used in borderline folks, and if they're going to be used, then how can we think about them that might be helpful? And then what do we need to expect? I mean, we would all like every medication to be a panacea, not just families, consumers, and patients. We who prescribe them would love that, would like them to be as powerful, so to speak, as they're probably not. So what are realistic expectations? And then we need to kind of stay thoughtful and organized with respect to using medications, because we don't want to necessarily give a medication or change a medication every time there's a crisis. So I think one of the hardest things that we as prescribers and or as clinicians have to do is to say to someone who's in a crisis, let's just wait. Call me tomorrow. Let's see what happens. Have you used your skills? Maybe we could think about talking to your boss or your roommate, and then let's see how things go. Because many of us who deal with these folks, either as or if you are a person who suffers from borderline personality disorder, you know that what looks absolutely impossible to deal with, and the feeling that I'm not going to be able to get through the next 15 minutes, the next day can be completely different, or certainly quite modified and mitigated. So you can appreciate that if you give a medication, every time there's this upsurge, two things are going to happen. I'm thinking about the World Series. You're going to run out of medications, and I'm thinking about when he had to use the pitchers as the pinch hitters. So you're not going to have any more medications to use, and you're going to get into polypharmacy, and what happens when you get into too many medications is you're probably going to be dealing more and more with drug-drug interactions, or you're also going to be dealing with people who are going to be quite unhappy, because ultimately most of them will gain weight, particularly when you're on a lot of medications. So, what do we make of the data? Where do we go from here? How do we understand using medications, particularly since none of these medications carry a specific indication for borderline personality disorder? If they did, we would all hear about that regularly, at least during the 7 to 8 hour when the news is on television. So we're using medications off-label, though in the United States, here in the U.S., probably 50% of the prescriptions that are written off-label, so that's not unusual, though in other countries that would be frowned upon, and it might not necessarily be a reimbursable expense. But then again, there's lots of things that are not reimbursable today in the United States. But what we seem to know, and this goes back to what Brian was saying about Joel Paris's comment, perhaps, is that medications appear to be less effective for symptoms or symptom complexes than when used in other disorders. And I want to talk about that in two different ways. So when Joel says that, we can give antipsychotics, but these people aren't really psychotic, or we can give antidepressants, but are we treating the depression that antidepressants have been mostly used for? That may be one reason why the medications are less effective, because we may be missing the target, or we may not necessarily be appreciating in detail what that word of psychoses or depression or bipolarity, mood instability means in that particular patient. That's the first thing. But on another level, in some kind of basic way, that these are people who do not seem to get as much bang for the buck from a medication, even if they did have a major depressive episode or a panic disorder. So an anecdote like that is, if a person has panic disorder, you can over time at least teach them, and I think we can do this now with borderline personality disorder, but let's go back 10 years or 15 years for a second. And they have panic disorder, and they, go to the emergency room, or they feel like they're going to die. But over time, and this gets back to this kind of maybe frontal lobe modifying the amygdala, that over time people begin to realize, oh my God, this is the panic disorder. I think I'm going to die, but I know I'm not going to really die, so I'm going to kind of excuse myself, go to the ladies' room or the men's room so I don't perspire and turn red and tremulous in public. I know it will pass in 15 minutes. And so they're beginning to cope with that. They can almost anticipate it, and it saves money with respect to not having to repeatedly call the EMS service to bring you to the hospital for another EKG. If you have people who have borderline personality disorder and panic disorder, they're using emergency services and using those ambulances for a much longer period of time than the person who has purely panic disorder. It's hard for them to quell the emotional reaction to the physiologic response. It takes them longer. So that may be another reason why medications don't appear to be as effective in this group of patients. But often we take the word depression to mean major depressive episode. And very often when borderline patients are talking about depression, they're talking about disappointment, they're talking about emptiness, they're talking about loneliness. And if that's heard only as depression, and then attempts are made to treat that depression, we don't have medications for emptiness, loneliness, boredom. We just don't have that. So there really needs to be, at least in the clinician's point perspective, a kind of a second or a third level of asking about questions and symptoms in order to determine what's really going on here. If you bring your car into one of the things that happens is when we bring our car into the dealership is the person that we tell the complaint to isn't the person that works on the car. And so you say squeak in the back, and they write squeak in the back, and they hand the thing to someone, they give it to someone, your car comes back and there's a squeak in the front. And if you listen to the people on Car Talk, whether you agree with them or not, they asked secondary and tertiary questions. When does it squeak? Does it squeak when you turn the corner? Does it squeak when you're on the highway? Does it squeak at all speeds? What does the squeak sound like? And that's very important, and it's very important from a clinical point of view. So depression is an adjective. It's a diagnostic entity, and as we all appreciate, it can describe an economic condition. So that we need to determine as clinicians what those words really mean and what's behind them. What is the individual experiencing? And I think that's the first step to trying to make some better sense of should we intervene pharmacologically, and then if so, then the trickier part is then which pharmacologic agent. So you have medications you can give to people, but if they have borderline personality disorder, they're going to be less responsive than if they had the same symptoms without borderline personality disorder. The other side of that is, but these are folks that seem to be exquisitely sensitive to the, to the side effects of the medications. And so what happens there is you change the cost-benefit of the use of those medications when you compare the cost-benefit to the use of those medications in patients who don't have personality disorder. So the benefit is less and the cost is more. So that's a different equation, and you have to think of that equation when you make a decision to use medications. And I think that, to go back, I wrote it down. We steal from each other, so Brian made some great things that I wrote down. But basically, you know, patients who have sensitivity to side effects to psychiatric medications, they also seem to have sensitivity to medications in general. In fact, they seem to have sensitivity or hypersensitivity to lots of things in their life. They're emotionally reactive. So they're not complaining of side effects simply to defeat us. They are, for all intents and purposes, experiencing those side effects. Whether you can hook them up to machines and measure nerve endings, they're experiencing those side effects. So again, that changes the cost-benefit structure in trying to make a decision. So I sometimes, it says I medicate first and ask questions later. It is a good joke. Unfortunately, we're asked to make decisions quickly. We're asked to make decisions sometimes in 15 or 30 minutes. We see people in emergency rooms. They are distressed. They're demanding medications. They've read about this in, Ladies' Home Journal, Men's Health. They've seen it on television, and they want it. And they want it because they really believe the success of marketing is that these things will work. And so it becomes important to kind of talk with them, to educate them, but to also not be rigid, and to make a suggestion. Well, let's see what the next 48 hours is. You can call me up, send me an email. This is not a definite thing. I've seen this before with you. I think things will be better. Let's not, it'll be complicated to add another medication. Let's just hold steady for the next day or two if you think that you could stand that. Whoops. So as I said, despite all the kind of cautions that I've just given forth with respect to using medications, and Brian talked about this as well, from the collaborative longitudinal study of personality disorders, which involved 5 medical centers essentially on the East Coast, and the work that Mary Zanamini did in her MSAD study, the McLean Study of Adult Development, this follow along that's now at 16, well, the 16-year data is coming out, that folks are being given medications. And both studies, the CLIP study and the MSAD study, are not treatment studies in the sense that these are folks that are in the community and they're doing whatever it is they're doing. They may be doing DBT, they may be doing mentalization-based therapy, they may not be doing anything, they may be getting medications from their primary care doc, they may be getting it from a psychiatrist. So it's a naturalistic study. You're looking at people every 2 years and making a measurement, but they're not in any controlled kind of treatment in that 2-year interval. And what Mary found, 78% of borderline patients were on medications, 75% over, this is the data from 6 years, and with 68 of the other, she had a personality disorder but not borderline comparison group over 6 years. And then 71% were still on medications at the time of the 6-year assessment, at that from 4 to 6 year interval assessment, with 54% of the other personality disorders. But this is what's telling, that 51% of the borderline patients were on 2 or more medications at 6 years, and 37% were on 3 or more medications at 6 years. I'm not suggesting that it's good or bad. I'm just going to suggest that life can get pretty complicated. You know, but one can appreciate why life might be complicated. So I've taken the 9 DSM-4 TR criteria, put it up there, and tried to say, okay, so if you just took this criterion, could you expect it to respond to medications? And so you can think that something about the unstable and intense interpersonal relationship, particularly if that's connected to emotional lability, that might, the plus minus, that might have some, medications might have some impact. Impulsivity, probably. Recurrent suicidal threats, gestures, or behaviors, depends what's behind it, what's driving that stuff. But I gave it a single plus. Affective instability, I gave it a single plus. Anger, a double plus. And stress-related paranoid ideation, a double plus, maybe even a triple plus. But abandonment, identity disturbance, and emptiness, which is often mistaken. I'll drive this point home over and over. I apologize. It's often mistaken for depression. There's no evidence that medications work there. So I don't know whether Perry's going to use this slide today. So this has to do with emptiness or loneliness or abandonment that you can't treat with medications. Here comes Earl. Remember, be gentle and firm. We are absolutely positively not driving him south for the winter. Though Brian says he's leading, he's going to take the SUV down. So I want to talk just a little bit about the trends in using psychiatric medications for borderline personality disorder, because I think they follow trends in psychiatry in general. And I think, again, if you're trying to figure out what medications to use, there may be something in the literature that says we use the medication du jour. We use the medication that's kind of up in front, that's a lot of work's being done, and I'll explain that in a minute. Again, I'm not saying that it's good or bad. I just think that these decisions, we ought to try and make them with our eyes open. So before DSM-3, which is 1980, that borderline was thought about as being on the border of psychosis, and we can discuss that in the question and answer period. But there was really an overlap between what we call schizotypal personality disorder and borderline personality disorder. That was divided out in DSM-3 reasonably well. It was divided out, but still the overlap persisted in people's minds, and I think that it still does sometimes. So during that time when borderline was thought of as being on the border of psychosis, the early pharmacologic studies were with antipsychotic medications. Made perfect sense, right? And then in the early after DSM-3 1980 period of time, the world was involved with, well, was BPD really part of a borderline, was a part of an affective disorder? The term was used, sub-affective disorder. That's like being sub-pregnant. I'm not really sure. Either you kind of make it or you don't, in my way of thinking. So, and also with post-traumatic stress disorder, because borderline was related to or thought of as being connected to trauma, and it probably is in somewhere between 50 and 75% of the cases. And people thought about the use of antidepressants, particularly the selective serotonin reuptake inhibitors, SSRIs, Prozac. But Prozac was then thought of in those days as kind of a cure for everything. We were going to slip it into the drinking water and everybody would be quite happy. So there was a lot of hope about the SSRIs, and then it would make sense that one would look at the use of SSRIs in BPD, and during the period of time from the late 80s through the 90s, the bulk of the studies were done on SSRIs, and that may be one of the reasons why the APA guidelines, which came out in 2001, but really reflect the review of the literature till about 1998, recommended SSRIs for 2 of the 3 algorithms, and I'll get to that. And then in the last decade, when everybody's been talking about borderline personality disorder as maybe there's a bipolar 1, bipolar 2, maybe borderline's bipolar 3, or it might be bipolar 7. One gets into thinking about the use of mood stabilizers, and most of the studies now have been done on the atypical antipsychotics and the mood stabilizers, and those are the drugs that now seem to be at the forefront of recommendations for use in borderline personality disorder. So one can't really appreciate all the stuff without, and where we are without appreciating its historical context. But also from someone who's, Perry said this, I spent most of my career at the University of Michigan. I spent all of my post-residency career at University of Michigan. It's a long time when I realized that, though I hope I didn't lose my Northeastern accent. So I'll tell one story. So I was fortunate enough to be invited to give a talk in Peru, and the woman who was doing simultaneous translation was just absolutely delightful, terribly conscientious. She met with me beforehand, and she wanted to know, was there anything that I was going to tell that was a joke or an anecdote? Because she wanted to hear it first, because she could put it in a certain tone that might make the joke work or the anecdote take hold. So I have this anecdote, which has to, and it's not unimportant. It has to do with the idea that borderline personality disorder is probably related to a biological predisposition as well as an invalidating environment. At least that's one concept. That's what Marsha Lenehan talks about. And I tell the story about my daughter that I come from 3 generations of anxiety neurotics. We came over from Europe. We brought it over. And that my daughter, my younger of 2 children, was anxious as a kid. And the dilemma was that she got anxious in the same situations where I got anxious. So I was pretty useless. That has to do with the match, you know. So in that situation, it wasn't very good. Fortunately, her mom, who gets anxious, didn't get anxious in those situations. And it gave me great pleasure to watch her mom deal with her in those situations where I was not really capable of doing it. And to watch my daughter, who's now 28, grow and mature and be able to handle things, I think, better at a certain age than I was. So the joke is that if I were her only parent, one of us would be dead by now and the other would be serving time for a felony. And so she was, I was telling this story, and she got more laughs than when I tell it in English. So I thought I'm going to hire her and take her with me wherever I go. So that one of the things that's happened in the 35 years that I've been doing beyond my residency work with borderline patients is that first it was, no, borderline doesn't exist, it's an affective disorder. No, it doesn't exist because it's a psychotic disorder. No, it doesn't exist because it's a bipolar disorder. You know, and one could get paranoid as a researcher in borderline personality disorder. They always seem to be kind of wanting to come at us, and they want it to be something else. And I think that what Brian didn't allude to in the study that showed that borderline patients remit, though as one goes out, there seems to be more recurrences than Mary first thought. But that's neither here nor there. But John Gunderson showed that to some degree, which really is important, that borderline patients don't recur, episodes don't recur at the frequency with which they recur in depression. And John has, goes back to 1991, John's been trying to write on the distinction between depression and borderline, and I've written a couple of papers like that as well. So if you take one of the hallmarks of how you distinguish diseases from one another, the courses are really, they're really very, very different. But people have already been kind of gunning for us, trying to get rid of the diagnosis. And, you know, when you have an academic career in first began to study the pharmacologic use of medications in personality disorders, they were trying to compare a diagnostic entity, borderline, let's say, to major depressive disorder. But what's happened more recently, to some degree, is, well, let's look at these dimensions that get disrupted across all of the personality disorders. There could be affective instability. There are issues with anxiety and the inhibition of anxiety or over-inhibition. Cognitive perceptual distortion. We try to kind of classify them into those four dimensions. So anger could actually be part of affective instability. They're underlined. So the APA did these algorithms, and algorithms are rule-based guidelines that has both strategic decisions, that is, what's wrong here, and tactical decisions. Okay? So that you've got a person that has a lot of anxiety, and you make that strategical decision, and then you might make a decision with respect to then how do you treat it? How do you go about treating it? And in the world of BPD, we have many more psychosocial or psychotherapeutic and evidence-based successful treatments than we do in the psychopharmacologic aspect. And when Paul Soloff did the initial offering, the algorithms in 1998 that he published in the Bulletin of Manager Clinic, that it later got literally adopted verbatim into the APA guidelines in 2001, he described it as an initial offering. I don't pretend to be anywhere near as good a scientist as Paul is. He's an exceptionally good scientist. But I at least said, well, if I want to criticize him, he did say it was an initial offering, so I'm going to make another offer here. Okay. So he tried to, what's most important is that I'm going to show you 23 studies that are used in most of the current reviews of borderline personality disorder, and Paul had access to only 7. And again, it was in that era when SSRIs were like the thing. And everybody was thinking that, again, that SSRIs could cure the world. So there were few atypicals. Only clozapine was reviewed by Paul. There were lithium, carbamazepine, and Depakote, valproate, were the major mood stabilizers available. SSRIs were the rage, and people were still thinking that monoamine oxidase inhibitors could be useful compounds, and they probably could be useful, but they were really pushed aside by the SSRIs. But I was just reviewing a paper on the way down here, looking at a thing called atypical depression in borderline, and monoamine oxidase inhibitors were often thought of as a treatment for atypical depression. But we didn't really have lamotrigine, topiramate, olanzapine, clozapine, quetiapine, aripiprazole, ziprasidone, or risperidone. So those drugs weren't out there for Paul to review. So what they said basically was that if you had a borderline personality disorder where mood lability and rejection sensitivity and or anger, your mood would crash, you should begin with an SSRI. And then if it didn't work, you could switch to another SSRI or another antidepressant. And then if that didn't work, you could use an antipsychotic medication. At that point in time, we didn't have the atypical antipsychotics. But basically, if you were impulsive and aggressive, you could also start off again with the SSRIs. And if that didn't work, then rather than waiting to the third step, to use a neuroleptic or to add a neuroleptic, you would add it in earlier, and then you would move to mood stabilizers at the third level. But if you had cognitive perceptual problems or transient paranoid ideation, you would use, at that point in time, the typical antipsychotics, because the only atypical that had been studied, and that was in an open study, was Clauser. So there have been, in the last 10 years, 7 what I would call systematic reviews or meta-analyses looking at studies of borderline personality disorder. And like all meta-analyses, you have to make some decision about whether or not you what studies you put in and you don't put into the meta-analysis. So meta-analyses were often thought of as these kind of pure things. Oh, well, my goodness, the meta-analysis, and makes adjustments for all these variables, but you still have to decide whether that study belongs in this meta-analysis. So there is a judgment made at the beginning. So there's about 23 studies, and these are them. These are the studies. And this was a systematic review. This is a systematic review of World Federation of Society of Psychiatry. This is by Connor Duggan from the UK. This is by Theo Enehoven he's from the Netherlands. This is a meta-analysis done out of Italy. Probably knows it. Cochrane review is a very systematic, thorough reviews of psychology in the UK. There were 2 Cochrane reviews, one that had reviewed only 10 studies and one that used 25. Cochrane review by Lee, that's in the British Journal of Psychiatry. This was the Toronto study, and this was, I mentioned, the National Institute of Clinical Psychology. So that's what those things mean. And basically what and this shows how many of those studies essentially were looked at in each one of those reviews, and that the ones in yellow were the ones that were available to Paul Soloff, so all the other ones Paul didn't have because they hadn't been done. And what I then did, and I'm really going to jump, and this is where you can kind of look at the tables. I went through each of the those reviews and tried to put them into a table of affective instability, aggressive. I hope you can pick me up on the sound. Aggressive impulsivity, cognitive perceptual, anxiety, inhibition, and then global function. So AD stands for antidepressants, AP antipsychotics, MS will stand for mood stabilizers. When there's a parenthesis around it, it means maybe. And so I'm going to go through all of these. There's no again, you can look at them in the book. But what do we conclude? So what we conclude is that first of all, a lot of the data is contradictory, even though the reason why I wanted to show that table, even though people look at the same studies, and even though there's about 16 or 17 of those studies that are in almost all of these reviews, they come up with different conclusions. Okay? It's humbling. But somebody said that if our brain was so easy to figure out, we wouldn't have the intelligence to do it. So looking at the data, we would say that if there's any evidence for treatment for affective instability, then the mood stabilizers show that evidence. And maybe there's some evidence for the antidepressants, but that evidence for the use of antidepressants with affective instability appears to be only when there is a major depressive episode. Sleep disturbance, appetite disturbance, more than 2 weeks, feeling guilty, the whole 9 yards of what the DSM would say is a major depressive episode, and not when the patient, has been depressed forever. I mean, I've had someone say, so you ask them how long they've been depressed, and they said, I was depressed in the womb. Okay? And again, they mean it, So depressed for 20 years is not a major depressive episode. It doesn't mean that they don't feel miserable, but it's not a major depressive episode. Okay? For aggressive and impulsive behavior, either the mood stabilizers or the antipsychotic medications may be the choice here. Either one, you could start off with mood stabilizers. If you don't feel like that's effective, you could stop the mood stabilizer and then use an atypical antipsychotic, or vice versa, start off with an atypical antipsychotic and then stop it and add a mood stabilizer. And you might then, after a period of time, decide to use both, but I would try each one solo before. And the cognitive perceptual disturbances, the antipsychotic medications, have been consistently shown to be effective over a 30-year period. For the transient psychotic stuff, and maybe for that kind of paranoid distortion when people are really emotionally dysregulated. So I just modified the Soloff algorithms, and you can look at that, but as modified, I just told you what those modifications are, but it's not a committee's modifications, it's my modification, so you have to take that with a grain of salt. So where does it leave us? It leaves us that there's a greater role maybe for mood stabilizers and antipsychotics, with a diminished role for antidepressants. And the role of psychopharmacology at this point in time is still adjunctive, where the meat of the improvement is really going to come out of psychosocial, psychotherapeutic interventions. And when we consider an algorithm, we need to recall that it gives us guidance and a decision tree, but also remember that the purpose of it is to revise it over time. So, and there are many contradictions that remain. So just to make a point, when DSM-5 comes out, if it ever comes out, you'll notice that it no longer has a Roman numeral 5. It has, I want to say, the cursive. It has just the number 5. But it's going to come out as 5.0, so that there will be updates, 5.1, as things go along, and hopefully you won't have to go spend another $175 as an update, but it'll be put online. But if anybody's thinking of publishing a book in the field of mental health, don't do it in 2013, because the DSM is coming out, and it's not a good year for sales, because everybody has to buy the new DSM. I got about 3 minutes. We can do that. We can do that later. And DSM, if it's a DSM thing, we can talk about that too. So, Erica Saunders, who's now at Penn State, and I, we looked at those same studies, and what we found was, well, why are there contradictions? And if you look at affective instability, these are all the different measures that were used across those 23 studies to measure affective instability. And they don't all stack on each other for anxiety inhibition, cognitive perceptual. So there are all these different measures. So, and some studies have 2 measures that measure improvement in depression, and some studies use one measure that's measuring more than one outcome. So you can appreciate that it's really difficult it's hard to build on these kinds of things. So do medications work here? The best that we can say is that they remain nonspecific in their response, that there's probably a high placebo response. Sometimes we can't appreciate whether medications are working until the person stops the medication. So that sometimes if a person's been on medication for 6 months and they're not sure that medication is working, and often the changes can be subtle because it can take anywhere between 4 weeks and 16 weeks to get a full effect on a medication, it isn't unwise. It may be wise to stop medications and see what happens again, and to get input from family members or friends as to whether or not the individual has gotten worse or more irritable